Good morning, good afternoon, or good evening to all of you. Thank you very much to the organizers for organizing this particular session and for inviting me to speak on the epidemiology, global burden of disease, and screening related to rheumatic heart disease. I'd like to start just by thanking the organizers for the kind invitation to speak among such an illustrious group of rheumatic heart disease experts. There are no disclosures to note. The pictures are all with permission from the patients, and I'd like to acknowledge the patients and the families living with and affected by RHD. I'd like to thank the funders of the various RHD studies over the years and send special greetings to my RHD colleagues, collaborators, and friends who have not seen for a long time. Let us start with the rheumatic heart disease. Absolutely key words that are associated with rheumatic heart: the only preventable cardiovascular disease, significant morbidity and mortality, and this issue that the long-term damage or permanent heart valve damage caused by ARF can result either from a single severe episode or from multiple recurrent episodes of the illness. It's focused in resource-poor settings in the world and affects up to 40 million people worldwide, predominantly children and young adults. I think most of us know the pathogenic pathway. We go from a susceptible individual to the infectious disease, acute streptococcal infection, to the immune-mediated disease, acute rheumatic fever, and then on to the chronic non-communicable disease. But this has also led to the siloed approach to this disease as well as to the interventions. And hopefully we can encourage you in this series of talks to think in a more comprehensive, comprehensive and integrated fashion. This is one of the best known graphics. It comes from a publication from 2005 and really galvanized the healthcare workers that were interested in rheumatic heart disease on our continent, in Africa, because it really showed that Africa was the hotspot of the disease at the time. It also pointed to hotspots of the disease in the Pacific Islands and a growing increase in the Indian subcontinent. Fast forward 11 years to the paper from and we can see now in this disability adjusted life years heat map that there has been some changes. Firstly, a much more granular look at what is happening to global burden, in this case to Delhi's, much more of a country representation rather than just a continent or region representation. But again, you can see these changes in continents. Africa is a good example, all the way from light blue to dark red, and then the Indian subcontinent, and then all the Pacific Islands are actually depicted in the smaller blocks. See, not only in terms of disability adjusted life years, but in terms of morbidity. This is from the Remedy study from 2016. And you can see here that the presenting complaints of patients with rheumatic heart disease to hospitals were profound. More than a quarter to a third had significant findings of heart failure, including presentation of heart failure, but also something like infective endocarditis and stroke was incredibly high, as was atrial fibrillation, if you consider that the mean age of these patients was only 26. When we looked at the incidence of morbid outcomes, again, outside of surgery, congestive heart failure events were the leading cause. And it just reminds us to focus on these two medical and surgical issues and how the one is to some degree much worse of a prognostic factor than the other. This is from the paper published by Damasceno et al. It's the thesis HF study. And here what they looked at is patients' outcomes after admission to emergency room with acute heart failure. You can see this is a disaggregation of the study, looking just at the patients that had rheumatic heart disease. There were about 40 of them. And you can see here how severely they were affected. So if you were admitted with acute heart failure from rheumatic heart disease, death to day 60, that's just 2 months, was 24.8%, and death today 186 months, 35.4%. In comparison, if you have a good surgical system, you can see the early post-operative mortality. This is from a small meta-analysis of South African studies, is extremely low. When we look at the mortality of that particular cohort, you can see affected was 16.9% of those that were enrolled in the study. The median age of death was 28. And you can see in the first year of the study, so reflecting that the Damasceno et al. Results was particularly high. A more detailed look at that shows once again the differential in terms of low middle income countries, lower middle income countries, and then upper middle income countries. And it's clear that the brunt of the disease is felt by those living in low income countries, as well as those who presented in congestive cardiac failure. Again, a very clear indication of the importance of medical treatment in this patient cohort. So those that were enrolled in congestive heart failure, the hazard ratio was 2.1. It was very clearly significant. So to summarize this section, rheumatic heart disease is highly endemic. The current numbers approach 40 million people living with the disease, more than 350,000 dying each year. Heart failure at presentation is associated with increased mortality as well as morbidity, and we have clear evidence from that from the Remedy and the Thesis HF studies. And still, it's low-income countries, those living in poverty and inequality, that bear the brunt of the cruel end of this disease. Some of the aspects of global burden. Just to remind you of the numbers and show you some of the trends. This was from 2017. At that stage, the deaths per year was thought to be around 319,000. And you can see the range between 297 and 337. Those affected, so prevalence was 33.4 million, and disability adjusted life years 10.7. We looked just 2 years later, the reviewed data showed deaths of around 306,000, but if you look at the spread from 259 as much as 340, the prevalence has now increased to at least 40.5 million, but as much as 50 million living with the disease, and disability adjusted life years has gone marginally increased from 10.5 to 10.7, and again a wider confidence interval. If in terms of a graph, you can see again the country here on the left. This is from the 2016 publication focusing on 2015 GBD data. What we were able to depict was a change in age standardized prevalence. You can see in certain countries in Africa an increase of as much as 20%. If you look at the number of prevalent cases, again across this middle band, which we saw in the disability adjusted life years heat map. If we look now at the supplementary figures on the right with these trends, you can see, for example, as we've mentioned before, the prevalence has increased, and associated with that is years lived with disability. But what is interesting is the flattening of the trajectory down for deaths, as well as for disability adjusted life years and years lived, years lives lost, and then disability adjusted life years. So as the prevalence increases at a very steep rate related to positive ascertainment, we see unfortunately that deaths are plateauing, as well as disability adjusted life years are slightly increasing. Remember the patient and the patient presentation. This is a 14-year-old girl taken from a very nice publication. If people would like to have a book read for a change, showing a severe mitral regurgitation at age 14 with the pathogenic mechanism of the mitral regurgitation depicted on the right. If this is sole mitral regurgitation, so pure mitral regurgitation, or pure mitral stenosis, there may be an option to do interventional interventions rather than surgery. The vast majority of the patients presenting, for example, in the Remedy study had a need for surgery. So if we look at this graph, you can see the pattern of native valve involvement includes large bands of patients with either mixed mitral and aortic valve disease in green, or patients with mixed aortic valve disease in yellow, and then in the blue, again, mixed mitral valve disease. And most of these patients will only be amenable to some kind of surgery. Yet, it's a very stark reality at the moment that there's once again this huge inequity in terms of surgical expertise in the world, in particular in the RHD endemic countries versus RHD non-endemic countries. You can see in Germany, 11.5 cardiac surgeons per million population compared to Nigeria, 0.06. Global burden, we also have to think about the socio-economic impact of this disease. This is from New Zealand, where they looked at group A strep alone, affecting 1.5% of the population each year and resulting in an economic burden of about 29.2 million New Zealand dollars. If we think about the other direction, how socioeconomic factors affect the progression of rheumatic heart disease, you can see here in countries where issues are important, such as in Uganda, overcrowding, unemployment, and the distance from the primary healthcare center. In India, issues relating to illiteracy and poor health literacy, low socioeconomic circumstances, a rural background, and then poor medical services and overcrowding in Fiji and Samoa. If we look now at some of the hard dollar costs, this is from David Watkins and his group looking at the economic impact of rheumatic heart disease in developing countries. You can see this was in 2010, where we looked only at 222 excess deaths. The cost was estimated at about 2.2 trillion discounted US dollars, or 5.4 trillion undiscounted dollars. And the economic consequences, both in pocket, both personal, and both population-wise, is tremendous. And a lot of work still needs to go into this particular area of research. We have the aftermath of COVID-19, and we know the human cost is what hit us the most during this particular time. In rheumatic heart disease, it is by far the cost to humans and to families that is the most profound. And now we have the possibility that COVID-19 and its economic implications could push even more people into poverty. And we contend that those with rheumatic heart disease will have serious considerations to be included in this particular population. The only way to deal with that is to provide and develop evidence-based programs that integrate with ministries of health and are able to provide broad-ranging services. These would include surgery, cardiac catheterization, the appropriate interventions immediately after valve repair, a team approach to cardio-obstetrics, both regional and even a healthcare worker level diagnostic program, and then of course personalized care and pharmacological treatment for heart failure. Funding for this is direly underserved. Funding for the research that underpins these evidence-based programs. This was a wonderful study from Colin McLeod looking at objective evidence of underfunding in rheumatic heart disease. He looked at 14 different neglected diseases, and you can see ranging from rheumatic heart disease to Chagas disease, and then indexed the disability adjusted life years for the amount of research and development funding. And you can see that rheumatic heart disease has by far the highest index, i.e. receives by far the least amount of funding relative to disease burden. It's important to remember, if we look at some of the numbers near the bottom of that bar graph, HIV affects 37 million, Chagas affects 3 million people. And this is quite a startling statistic. So if we put that all into place, 40 million people in the world affected with rheumatic heart disease, up to maybe 50, 35 million living with HIV, 3 million living with Chagas. Progress is sadly limited, and in some cases even slowing when we quantify the key areas of global burden. Funding is needed for research, for management, and for capacity. And the COVID-19 economic aftermath threatens to affect RHD endemic countries and further disrupt fragile health systems with dire consequences. As part of this talk, we're going to look specifically at screening. So screening really hit the international literature with this paper on the right-hand side by Marajan and his team from Cambodia, France, and Mozambique, which looked at the prevalence of rheumatic heart disease detected by echocardiographic screening, which showed a 10-fold increase when one compared the prevalence detected by auscultation versus echocardiography. The other big publication was the World Heart Federation criteria for echocardiographic diagnosis of rheumatic heart disease that was published in 2012, and then the incorporation of these two elements, and particularly the use of color Doppler echocardiography in the Jones criteria, which was revised in 2015. So we've had almost 2 decades of echocardiographic screening now. And so in 2007, the NEJM paper was published, and it looked just at the prevalence of rheumatic heart disease using portable echo. This led to echocardiographic screening in multiple countries. And at the beginning, first, different diagnostic criteria were applied to diagnose rheumatic heart disease. This led to an expert consortium getting together to look at a unified set of criteria published in 2012. And then these were applied to handheld echo, so even smaller than portable echo, as well as non-expert screening, probably in most of the endemic regions of the world. Around 2017, we started looking at long-term outcomes and trying to assess what happened to patients that were screen positive or almost in that case screen negative in countries that were affected. If we look at this meta-analysis from Rothenbuehler published in 2017, we see the different areas of the world and the different prevalence rates. In Asia, pooled prevalence rate of about 28. In Africa, 7.9, taking into consideration that some of the papers were from as early as 94. Oceania, 14%, Latin America, 4%, and overall prevalence of around 12.9%. We also started looking at different ways of looking at echocardiographic screening. This is one of them. This was looking at 2 studies from Ethiopia as well as from Zambia, where they looked at the prevalence in different parts of Ethiopia. This is looking at the difference between standard echocardiography and handheld echocardiography, especially using at that stage the V-scan. And the most important group has always been the definite rheumatic heart disease group. And you could see using handheld echo for the definite rheumatic heart disease group in a meta-analysis showed a sensitivity and specificity that were for both over 90%. There are many other lessons that have been learned from echocardiographic screening, how to incorporate elements of strep prevalence, how to teach non-experts or otherwise trained specialists. This is a radiographer from Zambia, how to develop appropriate support programs that went along with screening, this from Uganda, and then how to incorporate that into a control program, an interesting example from Fiji and Tonga. On the right-hand side, some other important elements, the differential between the different age groups, as well as site and confirmed rheumatic heart disease, the different areas in, for example, Ireland, monitoring of rheumatic heart disease, and of course, defining what is normal in terms of the variance that we see when we look very closely at the mitral valve. But as I mentioned, towards the end of that first decade, the issue of long-term prognostic tool and how we can use echocardiographic screening to either prevent a patient presenting with mitral stenosis, the way we see on the right-hand side, or to predict who would present with that, has become more and more important. If you see the various studies presented, you can see those that followed the patients longer. So this is Bayer from India, 24 months, Uganda, 27 months, and ourselves, 60 months. You started to see patients that progressed or got worse, but at the same time, you also saw an increase in patients getting better and returning to normal. When we looked at this in particular, you saw that the vast majority of the patients, 7 out of 10 of the definite cases, would remain much the same. But for example, if you look at the borderline cases, the majority, 20 of the 34, actually improved to normal. This is a very elegant study from Dan Engelman, where he looked at the difference between clinically detected, screen detective, and screen negative, and he looked at two variations. One is the issue of cumulative complications over a period of 10 years, and this is cumulative mortality over 10 years. If you look at cumulative complications here on the left-hand side, you can see that there was definitely a difference in those that was screen positive, as well as, so these are screen negative to screen positive. You see a statistically significant difference in complications, but this is even more so in those that were screen detected versus clinically detected. If you look at the mortality, however, you can see that those that were screen detected didn't have a different mortality over a period of 10 years to those that were screen negative, but certainly those who were clinically detected had a vastly different prognostic outcome. Turn our attention now to the second decade, where we moved away from prevalence and starting to answer other questions. The first was making handheld echo now almost a standard, and an amazing amount of work has gone into that particular area with new handheld echo machines, wireless probes, linking to smartphones, etc. The progression of the disease has been focused on very carefully, and also the costs and the cost effectiveness of screening and how we carefully and appropriately integrate screening into control and management programs. The next is the quality of life post-screening or even during the screening phase, especially for those who then need to go on to benzathine penicillin for a period of time. Non-expert screening started earlier on in the decade, but that actually moved into training of non-experts and doing that remotely and providing remote support. And then linking screening to care and implementations for global burden of disease. But we've always talked about how do we decide who to put on benzathine penicillin? Does this improve prognosis? And is the only way to check this with a randomized controlled trial? So some of the questions has been how to follow patients long term. Is it ethical to start any screening program or study without a long-term plan? What is the role of benzathine penicillin? What exactly does natural history mean? What would be the best methods to follow this? The DEFINE registry was developed to look at observational data, but what about a randomized controlled trial? What about those that are screen negative and then continue to live in high-risk situations? Should a screen be repeated at a later stage? And what about those borderlines that now approach 20 years of age? And what should we do in terms of follow-up into adulthood? And how long should penicillin be continued? This led to an immense and really exceptionally admirable program run by Andrea Beaton and Emil Kello from Uganda, the GOAL study, Protect the Heart of a Child, which closed at the beginning of this year and was a randomized control trial looking at the question, does penicillin prophylaxis improve outcomes for children with echo-detected rheumatic heart disease? So it compared patients in a randomized blinded trial over a 2-year period for those that were detected as having latent rheumatic heart disease and receiving prophylaxis to those who were not receiving prophylaxis. Just important to note, between the period 2018 to 2021, the team conducted over 100,000 screening echoes, 10,000 penicillin injections, tens of thousands of engagement calls to over 900 participant countries, and supported by an international advisory board, as well as a team of 4 reviewing thousands of echoes at 3 points time. The findings currently still under review for publication, perhaps by the time you listen to this already published, showed a progression of disease. You can see 3 out of the 399 patients in the BPG arm had worsening rheumatic heart disease compared to 33, almost tenfold more in the control arm. This meant a numbers needed to treat of 13.34, which means 13 children with latent rheumatic heart disease need to be treated with benzathine penicillin to ensure that one of them does not continue to progress to further disease. So if we put that all together, it's clear that we need expanded treatment options, research and advocacy so that we can address the burden of rheumatic heart disease. And this again is a very nice paper for people. So to summarize this part of this final part of the talk, echocardiographic screening for latent rheumatic heart disease is certainly here to stay. We need to carefully consider an integrated role within management and control programs. We need to understand that even though penicillin retards progression of disease, the supply is still unpredictable in RHD endemic regions. And managing patients with rheumatic heart is complex, expensive, and requires strong national health systems with a heart team providing adequate and appropriate and accessible primary, secondary, and tertiary services of a high quality. We are World Health Assembly in a few weeks' time, and in 2018 the World Health Assembly resolution on rheumatic heart disease was adopted. However, progress subsequent to that has, especially when we consider that rheumatic heart disease is a sentinel disease of poverty. It can be linked very clearly to universal health coverage, and all governments have already committed to establishing or furthering universal health coverage. And in RHD endemic countries, this should focus on inclusivity, coverage, and financial protection. And we contest that RHD services, which addresses the epidemiology, the global burden, and may even incorporate appropriately screening, should be included in UHC coverage packages. A recent Lancet commission came out with a comment: overcoming non-communicable diseases linked to poverty, such as rheumatic heart disease, is not a gesture of charity, it's an act of justice. Once again for your attention, for inviting me to give this talk, which really serves an introduction to wonderful talks to follow. And I thank the organizers and commend you for having this session. Thank you very much.